Welcome to our first Lunch and Learn in a series of 5 that we're doing across the New River Valley for the next couple of weeks. Lunch is on the way. We're getting lasagna and cheese ravioli and a big thing of salad from Sal's Jr. just down the road. So look forward to that. We've got drinks. So it'll be a nice lunch. Your lunch is free, but as a deal, we're going to ask for you to give us some input and be engaged in this conversation. Holly and I are sitting at the front of the room just to kind of help facilitate and share some really basic information. But at the end of this conversation, we really want it to be about you all giving us input, sharing your thoughts, giving us ideas, things that we can do collectively within our own shops and together as a region to address this terrible crisis that has affected so many lives, so many families here in the New River Valley. So I think what we'll do is just kind of start with introductions. And once food gets here, we'll take a break, grab food, and then come back and have the bulk of the discussion. Okay? Sound good? Housekeeping, there are restrooms out in this corridor. If you have to take a call, feel free to do that. Just step out and come back and join us as you can. If you have not signed the sign-in sheet at the back of the room, make sure that you do that before you leave. Is it anything? Live streaming. So please speak up when you do speak. And if you have a question, Holly or I will most likely repeat that question just for the sake of our audience that's watching live or via recording at a later time. Okay? That sound good? Well, sir, I'll start with you.
All right. I'm Anthony Wilson. I'm the retired police chief in Blacksburg and looking for something to get involved in.
Thank you. Glad you're here.
Noelle Bissell, Director, New River Health District.
Courtney Barr, here with Still Mine. I'm Rachel Jarvis, and I'm here with Community Health Center of the New River Valley.
Chris Alderman, New River Health District.
Jamie Regal and still mindfulness.
Pam Ray, New River Health District.
Sally Warburton, Pulaski County Library System.
Lynn Clark, Concerned Citizen.
Jack Watkins, New River Community College.
Amber Hammond, Community Housing Partners.
Stephanie Atkins, New River Community College.
Darla Blacksburg, and New River Health.
Helen Stewart, Sing. Sarah Fraser, Pavilion Clinic.
Mike Parmalee, Pulaski Community Partners.
Lisa Webb, AmeriCare Plus.
Anthony Akers, Assistant County Administrator for Pulaski County.
Susan Dalrymple, Virginia Tech Library Extension.
Charlie Mullins with the County of Dallas.
Holly Lesko, Community Health Director for New River Valley Regional Commission.
And I'm Mike Wade over the Valley Services. We are so grateful for you all taking time out of your busy schedules to be with us today to be a part of this conversation. You all know the numbers. You are probably very familiar with folks who have been impacted by this issue directly, indirectly, struggling with addiction, maybe passed away from overdose. This is hitting home. This isn't happening in larger metropolitan areas. This is a problem that we face here in our very community. And I think for us, in having these conversations and doing the work that we do, we can't change things on our own. There's no single entity or organization that can do this. There's no silver bullet to take care of this problem. I mean, if there were, we already be doing it. So I think it's important for us to have these conversations, to keep it out there, to address it, to talk about it, to figure out ways that we can work toward solutions. We may not always have the right answer. We may have to go back to the drawing board. I think we've already seen some of that. And things evolve with the nature of addiction. Fentanyl right now is enemy number one. Xyzilline is right behind. And so we have to be ever changing, ever evolving, adapting to meet the issue that's out there. And I think having these conversations and just being able to talk about it and to identify strategies, maybe things that we haven't thought about before, to look at it from different perspectives so we can collectively, hopefully, move the needle in a positive direction. So as we wait for food. Because I thought I was going to be here. Should we start talking about the ecosystem
I think that'd be great.
project?
In front of you, there's just a one pager. This, those of you who are, I mean, again, I feel like we're a little choir preaching now, but I think it's always good for the choir to understand the various ways we might sing together on this work. Back in January, we learned that the state was going to combine the opioid abatement settlement money that was coming to the state and split it among all the localities in the region. There are direct allocations going to each one of the localities. And when I say localities, those are cities and counties. In Virginia, towns are folded in with the counties in this case, so they do not get direct allocations, but they are part of our counties in the state of Virginia. In addition to that, they set aside money that was competitive funding that different localities could go after together if they went after it cooperatively. In the New River Valley, feel really lucky that we have had a real cooperative regional approach to many things in the past. So it wasn't a heavy lift to have a conversation across all of our jurisdictions, which include Pulaski, our meeting that we're having here today, City of Bradford, Montgomery County, Giles County, and Floyd County. All of the localities agreed to contribute or to put up their direct allocation as match for a competitive application to the state. Because of that, we were the only ones who did that. Because of that, we also received the highest allocation from the state in our cooperative application. As it says here, we got $2.1 million that also is that will be used for this work in a pretty broad stroke way. And the 1.2 million is in addition to that, that is from direct allocation that'll go to each one of the localities who have agreed to put this forward towards this cooperative application. It addresses a lot of elements of need in the area. We spent some time in March and April having meetings around particular topics, both for prevention as well as treatment, to gather information from various folks across the region and our localities to see where people thought our most pressing needs and goals should be for this application. We also made a decision to apply for 5 years of funding. You had the option to apply for 1 to 5 years. We did apply for 5 years of funding. So if we do well in this first year in our work, kicking off this work, we are set up to go back for additional funding the next 4 years after this. We have things in the proposal, some study money in this first year that have to do with things like supportive housing for people who are in recovery, as well as taking a look at adolescent treatment care in the region that we believe in years potentially 2, 3, or 4 could bear fruit to have facilities attached to them, so that we would go back for infrastructure funding. In this first year, there is infrastructure money in here for the New Life Expansion Treatment Center here in the New River Valley. So we already are going to be seeing some kind of bricks and mortar work with this, even though it is already a house, but the renovation needed to make it available for treatment. And then we're doing, there's a lot of funding in here for prevention. There's a lot of, even though, as those of you who are, again, swimming in water prevention for a long time, we know that we're not doing all the things we want to be doing around prevention in our schools. A lot of things happened during COVID where things got a lot worse for a lot of folks, and we're seeing even more concerns of underlying concerns for people that can contribute to addiction in our region, and we need resources to address them. So we're taking a look at some piloting programs in our schools, as well as with our drug court programs and our recovery court programs, as well as things like transportation. Like, how do we provide transportation for folks who need transportation to treatment, maybe transportation to services that they are required to participate in with their recovery court, and also getting to their jobs. We know that that's been an issue across this region for all folks in rural communities. So it's big. And as Mike said, we can't do this alone. One of the pieces of this proposal was really about trying to eliminate as many silos of work as we possibly could. A big piece of this innovation, I think, of what we're doing is the bus that the New River Health District got kind of towards the end of the pandemic. Didn't arrive in time potentially to do as much as we'd hoped for during the pandemic and getting vaccines and information out to folks. But it's a resource that we're now hoping to leverage to coordinate with work that New River Valley Community Services is doing, that Health Center, Community Health Center is doing, as well as the Health District, to reach people and hopefully to address some stigma associated with treatment, as well as information and education, that if we have people on this bus that are providing services to the whole community and making it mobile so that we're addressing some of those transportation access issues, we believe that we can build trust in the community. We can also address some underlying needs that might be impacting addiction for folks, and also educate ourselves about what the needs of the community are when we're out there in the streets. So that's kind of tip of the iceberg. We're going to be having a meeting on August 30th with the leadership group who came together and provided the matching funding for this, as well as are the key providers of services. We're going to be meeting on the 30th of August to revisit our missions and goals for this proposal, because when we pulled it together, frankly, we didn't have expectations that we would be fully funded. We thought they might pick and choose some of the things that we would do, and the fact that they agreed that what we were doing was the right approach to do a broader perspective of funding. We need to circle back with our leadership and make sure each locality is fully engaged and aligned with all of our work, as well as our partners understanding the need for that cross-sectionality of work in a separate. And all of you need to be involved. I mean, this is not, as Mike said, this is not a problem of other people. This is our community problem. We lose assets every time somebody isn't in a place where they can be fully participating in our community. And it impacts all of our families, all of our demographics, all of our communities. So we're going to be working together to address it and learn and adjust as we need. We have to be flexible. We know that's a piece of this work. And thankfully, the Opioid Abatement Funding and Authority has been very supportive of the fact that innovation is what they hope to see. They know that there's underlying work that needs to continue to be funded. We are doing some of that as well. And they expect us to reach for more than what we've done before. So that's what we're hoping to do. So, and we'll take everybody.
Yeah, and I think the other benefit of having these conversations and being more engaged with the process is that we can avoid duplication of effort without covering ground that we've already covered, or maybe replicating work that's already underway. There's so much that goes on around this issue that it's really hard to have a grasp of everything that happens. And so I think the more that we are engaged and have these discussions, the more we will recognize and understand what's already out there. What we don't need to do is put money and invest energy into things that are already underway, already happening, but then build upon what's already here and use this wonderful opportunity with all this funding to expand our potential and get help to the folks who need it most, and obviously prevent this from being again. Any initial thoughts? Lunch is on the way. I just got the text. Any initial thoughts or questions? Things you want to bring up before we start with lunch?
The 3.3 ends when? Is that a yearly?
That's our annual allocation for this year.
Okay, and it started July 1?
Yes, in theory. We do have 48 months for the first year to spend that funding because, frankly, Montgomery County hasn't yet. They're our fiscal agent for this process, and they haven't yet. We're not under contract yet for the funding, though we have been authorized to spend with the idea that there could be reimbursement as of July 1 for some of this work. There will be, a lot of us are considering hiring folks for this work. We need more people to be doing the work. As Mike said, there's lots of work going on, and there's just more work than we can possibly all do. So I don't think people should feel like, oh, I'm really interested in something, but somebody else is already doing that. We want to connect you with the people who are doing that work. We want to connect our organizations with each other about the work that's happening, and we believe that there's work for plenty of us all to do.
Two quick questions. I know this is opioid money. What's the latitude and flexibility for other substances that are being misused? I mean, around here, alcohol is a huge issue. Nicotine, huge issues, and these people are not unaffected by other similar stigmas attached with those. That's number one. The second one is under the evaluation and performance measures. Who's doing that, and what's that going to look like?
That is still to be determined. I think it'll be an outside, will be potentially one of our university partners, might be somebody who would do that evaluation to make sure that we're staying on track and that we are flexing when we need to flex. The idea isn't necessarily a authority saying you're doing this wrong and something, but that we're doing a constant reflection and adaptation of programming as we need to do it. So we'll definitely be working potentially with one of our university partners to do some of that evaluation. On the other side, as long as we can make a link that there is a connection to potential opioid use or prevention of opioid use, I don't think that we are going to be restricted. I do think that if our program became our prevention program became solidly focused on potentially nicotine and alcohol abuse, we probably would get pushback from the opioid abatement. And it is something that, this is funding kind of like Tobacco Commission money in the fact, but they are doing it a little more aggressively, making sure that the money is going directly to address the needs. So as long as we're working with populations that we believe are also at high risk
I mean, I'm concerned about the medical marijuana and the marijuana industry and what's going on. I mean, we're already seeing problems in the schools, and a lot of it's associated with vaping illicit substances through that method, not necessarily opioids. And I don't want to see, because we know that those are often gateways to more serious substance use. And so I'm just concerned that we don't want to drop that ball and at least there is a link there, and that we're trying to do prevention work.
I think any substance that people are misusing are something that would be part of a concern and a prevention concern. I think we're going to have to navigate that as we do it with all prevention work that we're doing and making sure that we stay educated about those pieces too. So I think our partners are all very aware of the other underlying concerns, just like transportation and poverty and access to jobs and social connections in our community, housing. I mean, all of those pieces have been supported in our proposal. So I don't think that there would be a reason to believe that any other substance misuse. I know we talked about it in Giles about that their meth is still a big concern there too. And there are plenty of connections between illicit, using that and other things.
Well, and the meth is tainted with fentanyl, because if you talk to law enforcement, they're using more and more of the naloxone because these people are taking meth and it's tainted with fentanyl. So it definitely fits in.
Also, our judge has indicated that would not be he felt like he would be able to articulate those are hand in hand.
The connections, yeah.
Yeah, and I think the prevention work is for substance use in general, so we'll get that for sure. So from the bus standpoint, yeah, it sat for a long time because we had to have the governor's permission to accept it. And it was a big bureaucracy, but we do have the bus running now, and we've got it wrapped with our New River Health District logo. And we are trying to get it out. And one need we have is CDL drivers. We have one CDL driver at the health district. And so if we plan to use the bus more, which I very much want to use the bus more, I need CDL drivers who can help us get it out and around. Because I can't ask my one person to do all the driving. So that's something where, as a community of people invested in this work, we are looking into, and people who join the MRC could actually drive the bus for us if they have a CDL. So that's one thing there. We got one down there.
I was just gonna say, New River has that as a program, so that is certainly something that we can promote and
Yeah, we definitely need CDL drivers. We can definitely expand what we're doing in that case, and using our MRC nurses and a lot of our other MRC who came out during the pandemic to do more events, I think will be really helpful. And so even before the pandemic started, we were starting to get on the road, and I'm gonna just bring it up. Where do I see the health department doing this? Because we certainly don't need to infringe on what anybody else is doing or duplicate what anyone else is doing. I definitely see that the health department can be involved in prevention, education, stigma. I think we all can be involved in that. And I'll be honest, even within my own staff, there's a lot of stigma that we have to break down, that we're working very, very hard. And I would say that everyone in here, we first have to reflect on our own staff and make sure that they're all on board with this, because I think there is still a lot of the perception that this is a choice, this is a moral failing. Even within the people doing the work that we do. So we are starting that within the health department now. We had really started to try and do it before the pandemic, and then of course the pandemic hit. So working on stigma, working on prevention education, doing more and more with the schools. We tend to dump everything in our schools because that's the touch point for a lot of our kids. And so trying to do whatever we can do to facilitate our schools, because I think getting to our children, that's our first step in prevention. Just talking about the ACEs and the generational poverty and all of how that contributes to what their risk is for substance use. So we can definitely help with that. We have our community health workers. We want to get out. We want to help in our schools. We want to help with prevention. We want to help with fighting the stigma in the education. Through PATH, we're trying to encourage more primary care providers to get involved in MAT as far as treatment. I know our community health center does MAT. Dave Roberts is a huge advocate.
It's medically assisted treatment. Yeah, so I forgot something like. MRC is medical reserve corps and MAT is medically assisted treatment.
So getting more people involved in treatment. And the reason that I feel that this is really important is because we're trying to get everyone to accept that this is another disease. And so we go to our primary care to treat our diabetes. We go to our primary care to treat our high blood pressure. We should be going to our primary care to treat our substance use. But more and more things, and this is coming from somebody who's an internist and who did primary care, just like we dump more and more on our teachers, we dump more and more on our law enforcement, we're dumping more and more on our primary care. So now our primary care are expected to treat everything, hepatitis. They're doing a lot of things that are out of their comfort zone. So if we're going to ask them to do medication-assisted treatment, we've got to make sure we have all the resources, the mental health resources, the counseling resources, and all of that to back them up. And that's where breaking down those silos, because I do think we can get more primary care to get into treating, as long as we tell them we've got your back and we're going to help you. Here's the counseling resources, here's the mental health resources, here's all those other resources to do that. And so I don't see a role for the health department per se in doing any of that. And then certainly NRVCS and the Community Health Center, they have the mental health, they have the outpatient treatment, they have the residential treatment, and then, all of our localities have the drug courts, they've got that. But then in harm reduction, the health department, just like NRVCS, we've been very active and engaged. Our community health workers have been fabulous getting out and getting the lock zone out to the community with all kinds of events. They did a lot of virtual things during COVID. They're on the ground now doing in-person at events all over the community. So again, that's one where we can collaborate. I love the train the trainer, where we just get more and more of it out there. Charlie Terracia is very, very active with the substance using community. So he's a huge asset to helping us get this stuff out there. But then the elephant in the room is syringe exchange, and as part of harm reduction. And that's something nobody else in the New River Health District is doing. That is something that the health department is willing to do to help pick up the pieces here. And I see the bus as a way to do that, because we can just get the bus out there to do mobile health department services. And so much else comes into it, because this population often has sexually transmitted infections, right? And so we want to test them and we want to get them treated for their their treatable illnesses. We want to offer them birth control to avoid the pregnancies, right? Because we know that mothers who use substances, their babies are born. You can have fetal alcohol syndrome, you can have neonatal abstinence syndrome. So obviously we actually had a very successful program in the jail where we went in and we tested and we educated, and we had to stop that during COVID. But everybody in the jail talked about how successful it was that we got in there and offered birth control. And we know a lot of the people are in the jail because of substance use issues. So again, offering all those services. And we talked about having some of our other partners go with us to offer the MAT on site. So I think there are a lot of creative things we can do. But then we would be willing to do that needle exchange part of it. And I know that is a tough ask for a lot of our communities right now. Everybody wants to talk about prevention. They want to talk about, let's put all the money there, but we still have to put the money into treatment. We still have to put the money into the harm reduction. And part of that is syringe exchange. And so that's where the health department's coming from. I oversaw all of Southwest for a period of time. Wise County has a very, very successful syringe exchange program. They've expanded that to Scott County. Smith County, anybody who knows Chip Schuler, the sheriff down there, big advocate. They have a very successful syringe exchange program, and they're expanding in that area as well.
Can you fill us in on how those decisions are made at a local level about whether or not to have those programs?
So when they first came out with it, in order for me to start syringe exchange, I had to physically have everybody sign off, from my local government to my local law enforcement. I had to get signatures. Now they changed it. And in fact, the state did an evaluation and they said we need more syringe exchange programs across the state, and health departments are, a way to do that. So now I don't need physical signatures. I can do my application through the state and get permission, but I really do need the buy-in of everybody at the local level. I need my local law enforcement buy-in. I need my local government buy-in. I need all of my local community partners to be on board with this for it to be successful. And a lot of that it goes along with just the education, again, the stigma, but the data is there. And so I need help getting the data out that these things really do work. They prevent the diseases that go along with it, whether it's a cellulitis, whether it's an endocarditis, abscesses, those kinds of things, the hepatitis C, the hepatitis B, all those things that are associated with sharing needles. And they also develop that trust in that relationship. They're like that starting point that we can then connect folks to other services. So people who aren't quite yet ready to go down that recovery path, if we can engage them, get them clean needles, have them develop some trust that we're not out there to hurt them, we're not out there to send them to jail, then they're much, much more likely to seek all the other services that all the other agencies offer to help with their substance use. And they're much, much more successful. And we have to accept, just like every other medical problem, that this is a disease that has relapses. And nobody goes through recovery efforts and gets it on the first try. Nobody does. So they may have some progress and then they may have some relapses. And so just like any other disease, we have to be patient and we have to be supportive. So that's my goal, and I want to put that application in, and I want to use the bus to do those health department services. But I think that's how the health department can contribute to this effort. It's probably the most.
It's a tough sell.
Yeah, it's probably the most tough sell, but we got to do it as part of this program.
Going back to the needle exchange, I work with Smith County, and since they've been doing that, it's reduced the hepatitis rates. It's reduced the number of needles that are around playgrounds. The more that people go in and exchange needles, they get educated a little bit more, they get relationships with the health department a little bit more. It's really been very beneficial.
It really is heartwarming, but we got to get that out there so people can accept it. And that's the biggest myth, that they're going to find needles all over the place. And that's not.
with the CDL drivers, if there was a way of, because that's a need in every county, if we could help provide the training for people to become a CDL driver. It's kind of,
Maybe we can use some of this transportation money to help you.
There's money.
All right, we got a good discussion underway. I'm going to push pause right there since the food is here. Jump back in and to try and help navigate the conversation because I know there's so much that we want to talk about. I think what we'll try to do is take blocks of time. And so here's my idea. We're kind of making this up. We're going to spend 15 minutes talking about all things harm reduction. Anything related to harm reduction, suggestions, ideas, whatever. Then we'll go to 15 minutes to talk about prevention. Then 15 minutes to talk about treatment. And then 15 minutes just to kind of close, do some final thoughts, and talk about potential next steps. Does that sound okay?
Yeah.
How's that for an agenda on the fly?
Just as a reminder, there is a sign in at the back. If you didn't sign in, please do and put your email because as opportunities arise, as we move things forward, we will be using that as a way to reach out. Please make sure you're already on the PCPC list.
So before we took the break for lunch, Dr. Bissell was talking about the importance of implementing syringe exchange. And I think that's a good maybe launch point to talk about harm reduction in this region. So any additional thoughts from others about syringe exchange, pros, cons, questions, things related to that? Yeah, Sally?
Fentanyl test strips.
Fentanyl test strips.
And I think one of the big problems is getting people on board. It's always not my backyard. And so even that building next door, right next door to the hospital in Pulaski was mixed. And so I think we need to get our communities, our community leaders, I think it's major that they get. Halfway houses.
What do you mean when you say a halfway house?
Like coming out of a treatment
Before you
or
go.
recovery. Yeah, there you go. What she said, the sober recovery house. It doesn't have to be an inpatient clinic, just someone that is in recovery that needs a place to stay. I think sometimes it all comes down to not my back. And that's unfortunate because, as Raising Lazarus says, would you rather have someone in treatment in your backyard, or would you rather have someone in active use? And so I think
That's an important point, I think. Let's face it, and I think Holly and I had this conversation yesterday. We can provide the best treatment supports and help for those who struggle with addiction, get them into recovery, get them to where they're in a good place. If they don't have safe, affordable, stable housing to live in, they're most likely going to go back to the area, the neighborhood, the community where they got in trouble in the first place. So that is a huge, huge need in this community.
Just to follow on the recovery housing, so the folks that I work with, we can find them housing, right? Because we have more Oxford houses in the community. We have holistic recovery housing, but then they probably don't have a job yet and they can't afford it. And so that's another barrier, is trying to help find funding to get them started, if we can even find the housing. So
Employment.
$3.3 million.
employment, money to first month rent, just to have a leg up. I mean, we got to get out into the workforce, into our employers, right? And get them engaged in this process. You talk about stigma there.
Well, and there's
I don't know if it's helpful to provide a little information on the housing side, because a lot of folks are working on the health side of just gaps and the challenges that how that pairs. So we work on the housing side on affordable housing development in the New River Valley. for the most part, that funding has supported those not within this sort of public target population. Even when we talk about affordable, it's like 50% area median income, 80%. So I would say we're actively working lower income families. What we lack is that no income to some sort of receiving some sort of benefit income. And how do we find housing for that? Oftentimes that same population is, facing a lot of barriers in terms of recovery or coming out of jail, and they don't qualify for even the subsidized housing that's available through the American Rescue Plan Act, the home program, which is provides sort of continual funding for affordable housing in our area, provided a special allocation that is focused on homelessness or at risk of homelessness, which I think really ties in with the population that we are all talking about. And so part of what we've been exploring is where does that relationship fit? How do we provide more low barrier housing? The main issues for our part of the state is that we don't have project-based vouchers. So you're given a housing, you can get a housing choice voucher, and those are hard to get, but then you have to still be able to qualify at a place, and so there are barriers there. So as part of this work, in order to provide housing, I think there is some sort of advocacy work that's needed to be done at the state level to try and get project-based vouchers for housing projects, because I think that we can, with some hard work, find some development funding, but to be able to provide that ongoing rental subsidy for whoever is managing and owning that property is pretty critical. And then that case management support in relationship to the housing and those non-health related services that are, there's services that aren't covered through Medicaid that right now no one can bill for, that we need to try and tackle in order to make some progress. I think that's helpful.
Ms. King. Any other thoughts around housing? Employment and other barriers for folks in recovery?
With housing, I work with some ladies from jail, but many of them will say, I don't want to go back home because my sister is my next room over and she's still using on my parents. But there is just very limited recovery housing in the way to get in. And leaving the area, of course, would be, it's good for them. Sometimes they don't want to, but generally they're pretty desperate enough to want to leave. And then looking at another barrier, training on stigma reduction, and you can do in churches, but reducing the stigma, educating people about stigma, in church environments, further comes forward. And as well as other things, but doing education at least churches.
On the stigma part of it, I'm passionate. I'm going to share something with one of my colleagues here. It talks about the word addict, and I just find it being so negative. When I look at a good friend of mine, Chris, I don't see an addict. I see an overcomer. I don't see someone at risk. I see him ready to excel. And he's getting married here soon. We're going to go across the big water and celebrate. But I think we got to change our mindset. And I agree that it is a disease, but I think that he can be healed from that disease and overcome that disease. And I just would love to see the treatment side. I'm still a law enforcement mindset, and the law enforcement mindset say something other than an addict. I think an addict is actively using, and someone that's in active recovery, I don't think he's still, there's concerns, but I just don't think that terminology is correct. And then the other stigma thing is typically there's several different groups and that silo, whether we like it or not, and I want to tear the silo down. But it's not from the treatment side and the law enforcement side, but the stigma comes from law enforcement. It can come from faith-based organizations. It can come whatever. I think law enforcement has moved a whole lot closer to the middle than treatment sometimes gives them credit. And I think that we got to guard ourselves because it is a team effort. And when we hit that against one another, that they don't move over. The law enforcement's closed-minded, and believe me, we are closed-minded as a rule. And but I think we've come a long ways, the law enforcement community, in that stigma issue. And I think we got to guard ourselves to continue that avenue. So 2 stigma things I have is, give credit sometimes to law enforcement because they have moved a little. And I would love to see society accept some other word than that. And I'd like to, does it offend you to be called an addict?
Well, I mean, yeah, it does. That's not who I am. At one point in my life, that's how I identified myself. That's what I was. But in the harm reduction world, we call people who use drugs, right? And we don't label them as anything. We bring them where they are as they are. And, I've worked in harm reduction the last 2 years. And what I know is that most people don't seek help because they don't feel safe there due to their previous experiences in the system, whether it's law enforcement, mental health, educational, whatever. They don't feel safe. And that there's a gap between people who are using drugs and treatment, right? So most of the people who are going to treatment are either arrested or they've hit some bottom. We can't, the drugs are different now, so we can't wait on people to hit a bottom. Like that terminology needs to be. Like if we wait on people to hit a bottom, that's just where we're at. Fentanyl is killing people. I've seen 2 overdoses of xylazine in Pulaski County in the last 2 weeks. Like it's there. And I've been to 2 trap houses in the last 2 days, one of them this morning in the bathroom. Right? So it is here. But the thing is, the most important thing is we have to treat people like human beings and not like their diagnosis or whatever label we have given them. Because the bottom line, I will die on this hill. All of this is rooted in childhood trauma. Every single bit. Been working in this field since 2009. And I've met one person that we labeled an addict that doesn't have some form of childhood trauma. That's the root of this. It's not the drugs, right? Because if that's the case, why aren't we doing the same thing with people who are eating too many Big Macs? You know what I'm saying? Because it kills people too. Or the people who are committing adultery and destroying families because that's some childhood trauma they have. Right? But we want to label the drug people who drugs because that's the easiest target. It's also the most damaging target. Right? We're kind of upset about it. Some people are understandably so. But the labels have got to go, especially in the harm reduction world, and meet people where they're at, because abstinence is not going to work for everybody. It's just not. I've seen too many people commit suicide because they couldn't maintain the abstinence model. That's insane. It should be. So, yeah, there's a lot of work to be done with harm reduction. I've got harm reduction stuff here. These are sharps boxes that I give to people. Also 2 pipes in here. Please don't arrest me, law enforcement folks. There is 2 pipes in here, and that's what it takes because we need people who connect with people on the ground who can assure them that this is safe. We're here to help you, not arrest you, not send you to treatment. I don't ever tell people, hey, ready to go to treatment. No, it's not about that. Right? So, sorry, that was a lot. I know I'm very passionate about this because so many people are dying about it. And it's like nobody even knows. Like in the Hep C statistics, would blow your mind. It's insane. So that's what this is about. The syringes are an incentive for people to come connect with us. That's it. It's a safe option for people to come and connect with us so we can show them that there is on the other side when they're ready. Right? It's an incentive. That's it. Sorry.
Chris, I agree, and we have to really open other people's eyes. And I always think about the faith community where they're already doing so much to help other groups and other people, mostly the downtrodden, the poorest of poor. They're turning to faith communities for assistance. And it's like, if we're not helping them understand the people that come to them, we're missing a golden opportunity. I look around here, I don't see anybody from the school system, and I don't see anybody from a faith-based community here. And why not? I don't know. But I think everyone can relate, Chris, to those childhood traumas. And maybe that's the first step. You open that door and say, you may not understand this, but let me just talk to you about ACEs. Let me talk to you about trauma-informed care. And I think that just levels the playing field. And it gives the opportunity for really important discussions that have to occur. Everyone doesn't end up in the same pathway. But I remember in NRVCS, I thought it had a great campaign, The Face of Addiction is Mine. And it really was, because everyone in here knows somebody or has gone through themselves with some form of addiction, whether it be the Macs, the Big Macs, or the chocolate, or the serious drugs, or hoarding. I mean, there's just so many things that people are addicted to. And I thought it was a great conversation starter, because it's don't point fingers, because boom, you yourself have something. And I think that's maybe the starting point of a lot of our important conversations, because this is a lot of money, but I'm going to stand here and just say education and prevention, not too successful for how many years now, right? We've been talking about this and it's not getting it done. So we have to really, I think, change our focus, make a left turn and go in a different way that this can have an impact. Having a lot of money does not guarantee success of a campaign. And if we're not reaching the people who need to be at this table with us, we're not going to have any success. And so I think we need to forget the past and figure out a new way, forging a new way, making new partnerships with law enforcement, having them say, you know what, I get this. Let's change the language. Maybe that goes to training when your new recruits come in. School systems. Kids that act out, it's because something else is going on in their home life. And punishing, I always talk to folks about vaping, and by the time they're in high school, if they're the frequent flyers of vaping, punishment, it's not going to cure them, right? And abstinence isn't going to work. We need to think about treatment, mental health services, and the ability to communicate well. And along those lines, I think, can any of this money be used to hire more behavioral health specialists, to hire more doctors that are willing to do MAT? Can we actually maybe team up with VCOM and say, hey, we know that your folks come back into this area. Can we help offset some of those costs by directing them into a field where they can help with this kind of treatment and this type of care? And I think outside the box for that, I don't know if this goes to salaries or not, but why not? If we have an identified need in this area for medical providers, whether it be mental or physical health, why aren't we putting money towards that? Because education and prevention, that's not going to work. We need treatment. Thank you.
I'll blow the whistle on the 15 minutes. And pick your poison. We can go to prevention or we can go to treatment.
I'm going to add on to Pam's comment. Med school is hugely expensive. There are very few grants, and you end up coming out of med school with a $500,000 debt. Paying off some of that school loans might encourage people to move in. I think psychologists have a little bit more leeway because they can get those where they teach like the freshman psychology classes, and they get their education free. They just have to pay housing. Med school doesn't have that stuff. But you end up with huge loans. And I think just offering to pay off loans, say come stay here for 5 or 10 years. We don't have any orthodontists. We don't have any, we're just talking OBGYNs in Pulaski County. We don't have professionals treating. If you want to get a doctor's appointment, it's like, well, let's look at September. A kid who needs a doctor's appointment doesn't want to look into September. They need one today. And so I think I agree with Pam. We need to figure out how to get some medical folks, both counseling and physical help.
There are some federal programs that help with loan repayment if you work in medically underserved areas,
Yes.
correct?
There
Yeah,
are,
there's the
but usually it's like if you go to Russell County, you usually have to be identified as a need.
So if there are those type of incentive programs that exist, but we're just not doing a good job of promoting that to students.
I'm where they promoted it to me. Yeah, the military was recruiting. So I was military, they only promoted public service.
Yeah.
Public health service.
So who would that fall to as we think about that? Would that be VCOM?
They do placement in rural places.
UVA Med School?
We've
we've got a lot of med schools.
I mean, it goes to men's.
UVA wide.
To promote waste recovery.
Well, and also
One in
provides
Richmond.
some training about substance use disorder too.
MCV.
Because that is typically part of very large part of it.
I would think that our healthcare systems would have some skin in the
Who
game.
is the lady that comes from VCOM on PCPC?
Teresa.
Teresa McCann. Yeah.
You got Curly in the room.
I think Charlie does work. But I can.
Yes.
And you got Virginia Tech Early School
Yeah.
House too, which is right in Roanoke. Those students come down and rotate at New River too.
There is staffing money in here. Quite a lot of staffing money to expand services and to do newer, different services, to staff the bus, like all of those things are, yeah.
I agree on this point. I'm just thinking, it's kind of two parts, right? It's expanding services and then it's like, what are the pathways to letting folks know about the services? I think that during the pandemic, Anthony, you and Dr. Bissett did a great job at working with local governments to get messaging and information out. And it makes me wonder, is there a way to replicate or build on that model to bring those of us that aren't health folks into the conversation a little bit more than just, focusing on like thinking of it as a picture.
And that's definitely the intention, and that, with the leadership group that's already, formed from some of the local governments as well as the primary organizations that are participating. And then the intention is to form technical teams that will looking at more specific areas. So people who have expertise in different organizations or real interest in communities. And one of the positions that we're talking about hiring is for lack of community accountability coordination. So we make sure that in Giles County, where there's a real interest or need in this area, that we're making sure that all of our partners and all of our organizations and any of the pilots that we're doing, that there's information being translated back and forth. That it will be incredibly complex. And I think that there still is a lot of things to be worked out logistically. But I think the intention of the localities is, coming off the pandemic, that we can do this.
Yeah.
We just have to not pretend like it's going to be easy. And also, make sure that we keep making space for people throughout the process to continue to enter. Because just because you're not here at the table today doesn't mean that in 6 months or in 2 years, when we're doing something that interests us, we have space for you to continue to.
I guess what I was just gonna add in there was communications folks at each locality can play a role in building a campaign. And even though you leadership, like having that communications team going can
There's started one. Mike Wade's on that team. and Jen Harris from Montgomery County, and we have Kim Bonner and ours. I mean, I do think, you're right. The model, nobody's trying to reinvent that wheel, I don't think. And we also are trying to be clear about, like, when we did the after action plan, bumps in the road that we learned along the way, trying to predict those a little bit too, and making sure the key, I think, to a lot of the work that was most successful was our ability to flex. And we just have to continue to be able to do that. Because this is, to Pam's point, we have to think there are things in the box that are really valuable that we're going to continue to use and keep doing. But there's lots of things that this opportunity allows us to consider for our region that I think before were hard to imagine because the resources just weren't there. And this allows some flexibility to make some real considerations. And we're still going to have to prioritize. It's good money, but it's not magic money. So we'll have to prioritize. But I think we're going to learn that hopefully along the way. And that is one thing, even talking with our supportive housing folks, like housing needs to understand what's going on in the medical community, which needs to understand what's going on in the food insecurity community. And we need to be sharing data in ways that would inform all of our work. way. And this, you know, could set us up for other funding that we really know would be useful too. So I don't, the intention is not to close any doors, and the intention is to make access to services more easy. Like if someone calls you and you don't know about, you know, the treatment, you know who to call.
Pulaski County High School now has a clinic right on the high
Community
school.
Health Center.
Yeah, and that's just amazing, but we need to make sure that we have available what needs to be available there.
Sure.
And
Well,
that you're not put on hold for 25 minutes when you call, or, you know, I know it's just in the startup phase, but we need to.
I think with this is the kind of data that will be useful to inform what the resources need to go. Definitely think we need to do that. I mean, and we've talked about this too. People who are seeking services through the community services, the community health center or health department, when we don't have the staff to do all the things, we probably never will have the staff to do all the things, but we can do more and be strategic about, you know, some of the places where we know we need to build.
Well, and just to like piggyback off of the school-based health clinic, which is an amazing program, they're not allowed to do anything substance use. So they're not
What'd
allowed
you say?
to, it's just basic clinic stuff.
right.
There's no, we're not available to do mental health or behavioral health services, even though we are identifying that, you know,
There's a need.
there is a need in our teenagers, and so I think there's a barrier there for something that could be a big asset to the community.
Well, and I know it's not, a lot of these, I know Giles has one, Pulaski has one, Radford. It's, Montgomery's the only one that doesn't do it. Sorry. Just one thing, there's dental care, and it's not just the students, it's staff
Yeah.
who are accessing that care too. I mean, we need to be thinking about our whole community and the need for access, yeah.
Yeah.
Thinking about what someone is called as a person, or since the person first, a person with a substance use disorder. Important.
Can you speak up, please?
Yeah, substance use disorder, I guess, is how someone can be identified as, and it can be a person with. But going to services we already have, it may be picked up with staff, the recovery support specialist, and they've got pretty large caseloads, and it's a wonderful resource. Other counties have it too, other CSBs, and I've worked with them in different ones, and they are just wonderful. They have the knowledge, they've been there, they've done that, and they are just really good to have as a resource for our community. We just need more help.
Is everybody familiar with the concept of a certified peer recovery specialist? That's someone with lived experience with a mental health and or substance use disorder that is in recovery and has been certified through training to provide supports and be a resource for folks who are actively struggling.
Can I piggyback on that a little bit?
Sure.
I mean, Chris and I have been in conversation about, and Chris, you can certainly jump in at any point with this, but in regards to the peer recovery specialist, he sort of offline after PCPC one day and talked about like the need that he sees for peer recovery specialists to maybe have some just bolstered education and training. And so we've been talking with folks at New River Community College to maybe create a certificate and be under human services that could be as short as a semester long to provide some of that extra, you know, again, jump in anytime, but like the
Yeah, I mean,
stuff.
that's what it is. When I started whenever I started, I was put into this peer position not knowing about, group counseling skills, didn't know much about it and all this stuff. And so peers would get put into this position, getting overwhelmed, and things can happen. That feeling, that trigger, that inadequacy feeling, and all this stuff again. So I think the more that we can get folks, and plus it introduces them to the community college lifestyle or whatever we want to call it, and gives them. So yeah, it's really just some intro classes to get familiar with the field. Because if we just do it based on experience alone, there's so much more.
You could be re-triggering.
Yeah, all it is, that especially, if we start talking about hiring peers for harm reduction. Yeah, it's huge. Um,
So I
Did the
think like
401 Peer Center get a huge grant to do that training? And that's ongoing, right? To
That
end up
is.
with a certain number of specialists in a certain amount of time, that's ongoing, right?
But this would be separate, this would be like additional. And this is the kind of thing that I think like these kinds of conversations, just being in the room or hearing where some of these gaps are, like you're mentioning. I mean, I was just talking to, Kim when we were eating, and she's sharing about these barriers to housing that I'm not even aware of. So again, and I know this is preaching to the choir, I like what you said earlier, but even, the choir needs practice sometimes. So, I think it is the more that we can be in rooms with each other, whether it's Zoom or other, to hear from these different, like, I don't know about the medical side, but we are trying to train people at New River to, provide, that there's a need in our larger community for medical staff. Now at New River Community College, it's, more entry level, but those positions are currently unmet too. So it's like, how do we look at it from the VCOM, from the doctor side, but also, more on the like short-term training, where are these gaps? How can we bolster, support, provide some extra, training for peer recovery specialists? But that's also then getting public advocacy to and word of mouth to spread, because right now they wouldn't have to do this, even though we see, and are in agreement that this could be really helpful, both to peer recovery specialists as well as for prevention. So I don't really know. I feel like I've gone off track, but I think what we're doing is good, and we just need to have some more of these conversations and almost like process mapping of seeing from the boots on the ground. Like Kim knows where those barriers are. Chris knows where other barriers and gaps in education and information and communication. So like, where is all of that, and then how do we plug these resources?
So is that kind of the thing, this sounds so much like a task force.
Yep.
You want to re-trigger it?
Yeah. The one thing that we were successful in, and it goes to the communication piece, was we tapped in to the pride of the New River Valley. It didn't exist. What we were going to build never existed. We didn't wait for the state. We didn't wait for the federal government. And we woke up, we encouraged a volunteer force of folks who never would have volunteered before. And that seems to be the structure. We got this incredible amount of folks who know the business and know what they want to do. But this has to be the roadshow of every community to say, you know what, we said enough. Enough is enough. And we are in the New River Valley. We're not waiting for the state of Virginia to come fix our problem. We're not waiting for the federal government to come up with some miracle to fix it. We're going to fix it. And this is what it's going to be, because you're going to find out, like we did, that everybody has a neighbor who looks like you, talks like you and everything, but has someone in their family who is suffering desperately. The whole family is doing it, and it's affecting us. And now it's killing our kids. And it is taking it from this piece and saying, we are accepting this challenge as a region. And this is going in front of every town council, every supervisors, it's going to school board meetings, it's going everywhere to say, hey, this is it. And we are going to make a collective, we're going to fix it. We're going to do a 5-year plan, I don't care, 10-year plan, whatever, but we are as a community not just going to do the treatment part, but the coolest part of the pandemic, if there ever was one, was waking up people, send them down country roads in every county we had to find not only people we wanted to test for COVID, but we also fed them. And we understood there was mental health problems that we had never seen live in concert. I might have heard about them or seen them in a law enforcement setting, but we exposed people to things they'd never, ever seen. And all of a sudden they became passionate about fixing. Is that where this piece getting to build? I mean, that's the piece. I see so much talent, but this piece, like, we just got to have a sword and just plunge it into the ground and say, we're done. We're going to fix it. And we're going to talk to every church. Anybody who wants to say it, it's everywhere. Is that?
There definitely is communication effort, and communication and outreach that has to, I think the intention around talking about this work is starting with this and gathering this kind of information. We need champions across the board and we know we need that, and we know also people who think this isn't their problem. It's mostly because they haven't seen it up close and personal, but it is all of our issue. So our intention is definitely to engage, make space for everybody, but also kind of to Chris's point, to meet people where they are too, because not everybody's going to be on the train with us to start, but we're not going to stop putting track down because not everybody's ready. We got to do some things. I know I got to slow my roll sometimes. I want to get busy doing stuff, but I think we also have to find space for people. What is it that people need to know to feel invited to this work, and what is it that people have to contribute? I know for myself, I want to know that what I'm doing is purposeful, and how do we invite people to this purposeful work in a way that is meeting them where their needs and goals and views of the world are, at the same time addressing this deep-seated concern in our community. Love for you to do some of that with us.
First, you drive the bus.
I would drive the bus.
Well, I think the parallels of approaching this issue in the same way that we have with COVID-19 pandemic makes a lot of sense. Now, I will say that as horrible as the pandemic was, there was some pretty basic messaging around prevention, keep yourself safe, get immunized, vaccinated, wear a mask, social distancing, pretty basic stuff that you can go by to keep yourself safe, keep your family safe. We know that addiction is a little more complicated than that, but there are things like Chris and I were talking earlier. If you take a substance, assuming that it's probably got fentanyl in it, space, don't take that chance, and be more accepting, be willing to support folks who struggle with addiction. Let's get rid of the stigma stuff. I had a cousin kicked out of drug court. I'll own that. Everybody's had somebody in their family or somebody who lives next door to them that's been through that at some point in the past. The scary thing about it is now, with fentanyl being what it is, somebody can make one mistake and lose their life. And I think that threat, I don't want to scare people. I don't want to use fear as a weapon, but that's the reality of where this thing is right now. One mistake can kill you. There are no second chances. So yeah, I think the threat and the fear of the COVID-19 pandemic does sort of parallel what we're dealing with here, although it's a little more complex. And I'm probably just rambling, but I do want to spend a few minutes talking about prevention education, because I think it does help feed into what we're talking about in raising the profile of this public health crisis that we're all faced with. It may not look like what we traditionally have thought about when it comes to prevention. For years, our agency went into the classroom, 6th and 9th graders, and talked about the dangers of substances. By the time kids get into 6th grade, they know a lot of stuff. They may be even trying some stuff. We hear from school folks all the time who are taking vape pens from 3rd graders these days. So it's out there. They're getting their hands on it. The traditional programming of going into a classroom for 45 minutes a week to talk about how bad things are, forget it. That's not how prevention needs to be working. So I do think it's about trying to think upstream, think about the root causes of addiction, childhood trauma, the things that feed into that generational poverty we were talking about earlier. All those factors that contribute to someone developing a problem with substance use disorders. So we got to think upstream when it comes to prevention, and not wait until we're in 6th and 9th grade to talk about how bad this is, because they already know. They're seeing it in their own homes. If they're not using, their parents, their guardians, their grandparents, they're using. So we're not going to educate kids in that way. We need to work with families of very young children. We need to work with people before they become parents to talk about this stuff. And I think that's where prevention can be effective, if we think way upstream, not when it's too late.
And also talking about it from a risk reduction place, because I do think that the line between prevention and harm reduction is not as solid as people think it is. And I think the continuum of care that we're talking about in this process has to include lots and lots of pieces. And as we say, you know, person with a substance use disorder, you've met one, you've met one. Like there, everybody comes, even though trauma, I believe, is at the core of some of what might trigger someone to use. It might also be an experimental opportunity that somebody had and that you can become addicted that way. And so I do think we have to talk carefully about how we define folks, how we define addiction, and how we define, to your point, prevention. It can be, you know, housing is prevention, jobs are prevention, you know, transportation is prevention. And I think that's different audiences need to hear different ways of supporting this.
Other thoughts around prevention, education, awareness?
I think a lot of it, I mean, there's a lot of stigma in the schools too. I got a son that's 15 at Pulaski. Tons of kids, not tons, but a few kids that I've raised that's went to Pulaski schools. And, you know, the thing is that, you know, the vape pens and all these things, you know, once we know why they're doing it, then we'll know what to do. You know, that's one of those things that is so individualized. You know what I mean? There is no way that anyone can say, well, this kid is vaping because all the kids are doing it. It's not necessarily true. It's true for some. Some are doing it to fit in. Some are doing it because mom and dad are here. Some are doing it because whatever reasons. But, you know, I think that a couple things. I think trauma-informed design is important in the schools. Understanding that this is not a woke culture thing. I know that term gets thrown around about, you know, the feelings police and all this kind of stuff. But the reality is the kids in these schools have experienced COVID, which was traumatic for some of them because now they're stuck in a toxic home where they're getting abused every single day. They don't get that 8 or 10 hour break, you know. So having trauma-informed design, which also means get rid of these things, fluorescent lights, and having more of a softer appeal to help kids feel safe. School shootings are a thing too. My son, there was a school shooting one time, not around here obviously, but he saw it on the news and he sent me a text and it was freaking out. Right? Kids don't feel safe in school. They don't feel safe at home. Of course they're going to go somewhere where they do drugs that are going to make them feel that illusion of safety. So, you know, I think that understanding that us as a community, us as a country, us as a society have all experienced some really heavy stuff the past few years. Everything from George Floyd to COVID to Russian, all this stuff. And kids and adults feel that. Like it's not. So I think we really, you know, I think looking at our own biases and some of the things, I know I had to look at everything that I was taught my whole life and kind of decide for myself what I believe is the truth and what's not. And I think that all of us can do that. You know, the shame and coercion, you know, we've tried that for years with treatment. Works for some, but we still had 110,000 people overdose and died in 2022, which was up from 108,000 in 2021. So that hasn't been working. So,
Jack?
Yeah, I was just going to build on what you said, Mike. I think, you know, you talked about going the educational systems. I look around this room and everyone here is extremely qualified to be here, but I think as well, it also boils down to getting the youth involved. We've talked a lot about the youth, but we're not getting their opinion. And maybe you guys are, but I think even when it breaks down to the monitoring and evaluation of programs, working with the youth, finding and identifying leaders who are living this, who are experiencing it, and quite honestly, who it affects the most. These programs, it's great for us to talk about, but at the end of the day, these programs are long lasting and they impact the youth the most. And that goes for teachers who are seeing it firsthand. It's great to talk to administrators, but at the end of the day, teachers are the ones who are interacting with this. They're that first line of defense. You know, we talked about doctors. Doctors are great. Nurses are usually the ones who do the most interacting. Making sure we have people who are seeing it firsthand and not just, you know, the bird's eye view is great, but sometimes the people that are in the trenches have some of the best opinions and have some of that inside knowledge and see things we're missing. It's, you know, the same when we have our peers leave these sessions and we have people who are in recovery who've experienced it. They know it works because they know and because they can relate. I think with a lot of the programming, especially at the youth level, if you're not talking to the youth, if you're not working with them, you know, it's like when you see an old guy say, "That's it." Nobody cares. That doesn't work. You can't. It's all good and fair when we're coming up with these programs and you're looking at what it's defined by a textbook, it's successful and it's great. But at the end of the day, if you're not getting the youth involved and finding ways to get some of that buy-in, as well as just piquing their interest, it's not going to go that far in terms of prevention. And same goes for police officers. Those guys know firsthand what's going on, what they see. They know their experiences. If we're not pulling those in the same way we're working with teachers and with these youth, it's great to look at how we're going to prevent things. But it's also important to pull in that firsthand knowledge for somebody to say, hey, when you're looking at the nuts and bolts of this isn't going to work because of X, Y, and Z. Or this idea is great, but the youth are never going to buy into this because of X, Y, and Z. Or even for a teacher to say, hey, it's all like, yeah, I did pull a vape from a kid. But in reality, this is what this looks like on a day-to-day basis. And those perspectives are really important. And I think we do have to find ways to fit that in and work that into the system, or else it's all just going to collapse.
Two things. We do teen mental health first aid training in other areas in Virginia. And that's where we do adult and we do youth, but teen is going and teaching their peers on how to handle or be there for someone that is, and recognize the issue that's going on and includes substance abuse. And so I think that would be something really good. It's pretty stringent on, you have to have a whole grade invested in it. Just pick and choose certain classes. And the other thing is, I went to a workshop, we were going to be there it was on overdose mail. Oh my gosh, I had no idea. It's been out for like over a year, and you incorporate police officers reporting overdoses, ER does, CSBs, health departments. And when you have, say, a bad batch of pills coming down the road, if we're in court coming down this interstate, that it could show where you're having more overdoses than normal up here, say, in New York, and you can see it come down, people reporting it, coming down the interstate, and getting that knowledge out there to prevent overdoses, or your Facebook page, your Facebook pages for all our organizations. And it was just eye-opening. Some of these states have been doing a lot more than Virginia, but it's incorporating everything. We need to know when we've got a bad batch of fentanyl coming down and people are dying.
Go.
I've seen the OD map. The only issue I'm having with it is it's not getting reported soon enough, and so we're getting stuff that happened a week ago.
Time out.
But
Go the other route. The
Which one?
slam dunk, the
the odor.
Yeah.
Oh,
Oh yeah, no, I had a dream one night, literally, that I think that one of the issues, well, there's so many, but a barrier is getting people to care as soon as they overdose or as soon as they're ready to go get treatment or whatever the case may be. But I really believe in an overdose emergency room, and I think that maybe in 50 years it might happen. But the ER staff, and this is no disrespect to them because I know their jobs are intense, but they treat people with drugs poorly. Not all of them, but some, and it only takes one. And I really think that if we had a place dedicated to people when they overdose, we take them to get the care they needed. They need to get whatever they need at that time. Whether it's medical care, mental health care, treatment. We got more treatment resources now than we've ever had, like literally. But we've also got more overdoses than we've ever had. Of course, the drugs are more dangerous. That plays a huge part. But these folks have got to be able to feel safe wanting to get help. The withdrawals is going to keep people using. That's why people continue to use opiates, is because they don't want to experience the withdrawals. They're not going to go to the hospital and get help when they're withdrawing because they know they're going to get treated like dirt and probably get put in get TV, whatever may happen. That's what's in their mind. And so, a place where people can go get the services they need rather than have to go to a hospital where those folks. I took a friend last month, he used some fentanyl, he was intending on killing himself, picked him up from a hotel, took him to the ER, they literally took him out of my car, took him somewhere, sprayed him off with freaking water. Why is that? We don't eliminate the myth you can't touch fentanyl with overdose. Okay, it's not going to happen. So why is our ER doctors hosing down people like it's freaking 1950? Don't understand.
He had shared this with me a month ago, that those people, these individuals are very vulnerable at that time, and they're willing to get help. They're interested in help, but they have no trust in the system. they're not going, even though they just overdosed, they will resist going to the ER because of the stigma associated but if it was a trust area where they could go, their minds are open to start that step of recovery, but they avoid that because they have no trust in the system we have. I had never thought about that. I've been in the arena for a while, and I had never even thought about it. That's when we could really strike gold, is when that individual is in desperate need and he needs help, but he's not going to seek it out. I got one other thing to say. I'm a loudmouth, get involved, never shut up guy, but I got to leave it to say. I want to make a personal pitch. I think the key to this whole thing, the $3.5 million, which I want Giles to get 3.1. I'm not trying to be greedy. I'm just trying to get our share. Is we have to have leadership. One of the things that they're planning on doing immediately is start advertising for, I don't want to say drug czar, but a leader of this concept, because we feel like accountability is going to be huge in order to maintain the grant as we move forward. And we have a perfect model of what we need to do. And we have two perfect leaders that have been down this road. And when Anthony said that we need everybody, we need school teachers, we need police officers, we know it all, thinks he knows it all guy, and we need the faith-based, we need everyone. And you have organized it before. And Virginia Tech football, I love it. Absolutely love it. But they could live without you. And I highly encourage us to promote Anthony Wilson. I'm voting Anthony Wilson for a regional coordinator. And I think the manager needs to be set aside. I think if we could hire those two people, I think the bus would go in the right direction. My true belief. Or somebody very similar to both of them. All these ideals are great, but if we don't have somebody take the bull by the horn, he's chewed me out over the pandemic. I was late 3 minutes on delivering some test strips one time. And I've got this knucklehead kid doing it who gets chewed out. Charlie. But my guy was 3 minutes late. It wasn't 1:33, guys. The time to be there was 1:30. I think it's key to get good leadership. And I encourage you to apply. All right, sorry. Chris, if you're watching, I'll take next week off.
Any additional thoughts before we close? Promise we'll be done by 1 o'clock. It's 7 minutes before. So.
Just one question. When will all of this, we talk about this is already happening, it's already written here. When will we get to see that final package? Is that after you have everybody on board and you signed an MOU so that you can say this is what went into all of these phases so that we can see it and look at it and understand how it was parsed up?
Yeah, MOUs will have to happen with Montgomery County. Each of the localities have to sign resolutions to commit their match for this piece. All of the organizations that are doing some of the work will have to be signed on with MOUs. So yeah, all of that will be public, of course. And then what I want to say is that we have to build in flexibility, because no matter what we do, no matter how we start, we are going to change it. We are probably going to, we talk about that all the time. That a week in, we may find that, one of the things we really want to do is some coaching with teachers in the school system. And we want to do a pilot program, and we have some ideas of where that pilot might happen. And that coach, maybe we are going to struggle to find that person to do that work. So we might end up hiring a couple of part-time people instead to start something. I just want to be clear that our goals are going to be very clear. And we're going to be crystal clear about the engagement of the community in all of this work throughout it. And that means that the process is going to have to flex a lot, very much like we did during COVID. Every week we learn something new, and we're going to learn new things here too. Hopefully I'll learn a ton of new things when we're doing it. But I think that the idea is that we need everybody to help us, that accountability. We're going to hire somebody to do some of that tracking, but we're all accountable to this work. And each organization that's doing some of the work isn't on their own doing it. Even though NRVCS is going to be doing a lot, they won't be alone.
Can I ask a question? And you may not have an answer to this yet, but you guys have a vision of how you want all of the partners to engage in terms of like the structure, and you talked about an accountability person and then a manager. And that there's some sort of leadership team. Can you explain?
There is an evolving organizational chart that is complex. And I think that on the 30th of August, we're going to be working with our leadership to get something that is a clearer path of exactly how those pieces come together. Montgomery County is the fiscal agent. They are the ones who agreed to be on the hook to the authority, and the regional commission is doing some of that basic staffing and coordination, facilitated coordination. But it will be complex, and I don't want to duck the complexity. I think that's what we're trying hard not to do, is to say, here's the person who will make all the decisions. I think there's going to be people at the local governments, obviously and rightfully, want to maintain some control of what's happening in each one of their localities. And that makes it complicated, but it also means that the New River Valley as a region has done this work before, that complex work before. And I think we can do it again.
So,
Yeah, but that was one of my questions. And then the second was, would it be helpful, I guess in my head, the way that I organize things, I'm like, would it be helpful as a follow-up for those of us who are in this room and then the rooms that you're going to have subsequent to this to share? Like, I mean, as I'm listening, I'm thinking, gosh, I think we could partner with them, or I think that might help fill this gap. Like, for us to just
Put stuff out there.
to you. I mean, is there like a formal way to do that, or what?
Not yet.
What you're hearing, not yet.
Not yet.
but I do want to say, if there's anything that you walk away from today that pops up in your mind you think might be a potential strategy for us to pursue or something that's worthwhile, just go ahead and send it to either Hyland or myself. And we'll make note of that and then incorporate that into the meeting that has to come.
So we're really still gathering,
Yeah.
even though there has been an award, there aren't things in stone about that yet. So this is an opportunity for us to share back to that leadership group about where the energy is in the region. So if you've got energy, share it.
I'll just throw out a final thought that I heard the term advocacy come up quite a bit today, used around different things that came up, but I think that's important for us. We have to be the voice of this issue. We have to represent the people who struggle. We have to be their champions and speak on their behalf, because the nature of their disease is they often don't have the ability. They're not in a place where they can do that for themselves. So we have to combat the stigma around addiction. We have to build a region, society that promotes empathy, support, love, and understanding for these folks. And that's how we all get better. So thank you for your time. We'll send a summary of just some of the points that came up to everybody that shared their email address. And if you are not already actively involved with the Pulaski Community Partners Coalition, we typically meet the first Wednesday of each month at 10:30 a.m. over Zoom. And we talk a lot about this kind of stuff in our meetings on a regular basis. So we'd love to have you join us, be part of the solution.
Did you say before we go?
As our Pulaski governmental rep.
Well, no, I was going to reiterate what Mike said about how active Pulaski Community Partners Coalition is. And appreciate you to invite. And knowledge is the key about learning this thing. But that's what I just want to say. Thank you for that plug. What's going on in the rest of the New River Valley. So
Thank you all so much for your time this afternoon.